cardiovascular surgery and had an opportunity to participate in a case that not many students have an opportunity to participate with. And we are very, very proud of all of our students. Our clinical students are doing extremely well. I'm getting lots of great feedback out in the community of how professional they are out on the rotations and how smart and bright these kids are. So I thank you for coming, and we want to share the story. Kayla?
Hi, so like you said, my name is Kayla Miles. I had the opportunity of being with Living Children's Hospital. I'm right in downtown Charlotte working with the Pediatric Cardiothoracic team. And I was lucky enough to be a part of this young boy's kind of staging in his life, and he ended up needing a heart transplant. So kind of just to make it easy, I'm going to start by telling you what he had and then kind of telling you about his journey and kind of what you've been through. And there's just a small image of me actually first assisting on one of the heart surgeries. So this 10-year-old boy, he had something called left hypoplastic heart syndrome. Mainly throughout this presentation, I did a lot of pictures instead of words, because it's easier to understand. So this is pretty much just a single ventricular heart disease. So you only have one functioning ventricle. So you can see here in this patient, he pretty much didn't have a left ventricle, and he was born that way. During prenatally, they were able to diagnose him before. And the cause of that is mainly related to the AV valve. So in this situation, it would be your mitral valve, which usually would sit right here, also called mitral atresia. And atresia just means an absence or abnormal narrowing of any part of the body. This situation, it was the left side of the heart, so it was mitral, but you can also have tricuspid atresia, which would just be the same thing, just on the right side of the heart. Little different procedures, but I'm just going to go over the left side of the heart. So like I said, during fetal life, there's the valve is too small, you have inadequate blood flow to the chamber below it, and it doesn't develop properly. So here's some photos comparing. The one all the way to the right is how hopefully everyone in this room heart is functioning. And then the one to the left is the 10-year-old, how he was born. So you can see the biggest thing here, like I said, the small left ventricle. But the biggest things that these kids need is they need the mixing of blood flow. So you see that they have an ASD and a PFO, which is all the way up, PDA up there. I wish I had like a pointer. But the number one sign of this is just inadequate cardiac output, and eventually causes the most severe form of congenital heart disease. You can see all the different things listed, the mitral stenosis to atresia, left ventricle hypoplasia, all the other stuff is pretty much what you see in that image there. So this is just some pathophysiology of it. Typically, there's no adequate blood flow across the aortic valve stemming from the mitral atresia, and the shunting that occurs at the two sites, which is what I mentioned in the last slide, the PDA and then the ASD. The biggest thing, the blood flow through the left heart is obstructed, and you have the postnatal closure of the PDA, which ends up causing that decrease in cardiac output. And if this is something that isn't done within the first week of life, surgically, they usually only last a month. So the next slide, you'll see there's 3 different procedures that this infant went through. For every single one of these, the Norwood, Glenn, Fontana are all named after famous heart surgeons. So the Norwood's the first one. So this is the one that you do during your first week of life. And you can kind of see here the small left ventricle. You see the ASD. And the one thing I like about these images, everything purple shows you the mixing of blue blood and red blood. And then obviously, this is superior vena cava, inferior vena cava, everything's normal here. But then you have the mixing of blood across this ASD. And then, so what we would do in this procedure is the first repair. I'll go over into more details and more slides, is you cut the PDA, you cut this off, and then you put a shunt there. I'll go into more detail later. And then you have the Glenn, which is usually done about 4 to 6 months of life. And then you have the Fontana, which is kind of the last one, which is done at 3 years of life. And then lastly, usually most patients need a heart transplant. And the biggest thing, like I said, I'll talk about it later on, The reason to kind of, the child needs a heart transplant is when they start having liver function. I'll go into more detail that later. So this is the Norwood. So you can see the preoperative anatomy. You got the PDA, the pulmonary artery, all the other stuff. So what we did, you can see the really skinny aorta. So you almost have to cut that open and make it a little bigger. You put patches in because you want to make sure that it's big enough to get all the blood flow to go to the heart. And then the biggest thing of this is the shunt's put into place. And you put it from the right ventricle all the way up to the pulmonary artery. And the reason for that is you're making the single ventricle, the right ventricle, now the ventricle that flows to the rest of the body instead of the left ventricle before. So the biggest thing there is that obviously there's lack of blood supply, involves this larger operation. So the mortality for this one is 20 to 25%. So it's pretty high. And then I think the coolest thing about this, you're literally just reconfiguring the entire anatomy of the heart, which seeing it is really cool. I think I was able to see 4 different Norwood operations during my rotation. And then the reason they put, this is called a Sano shunt, that tube to the side. Another one you can do is also called a BT shunt, which is something that would go from here to here. And I ask the surgeons a lot. Most of them all do the Sano shunt, and they think it provides better pulmonary blood flow and incorporates, like I said, they use from the RV to the PA. And the reason for the Sano is it prevents the diastolic runoff from the systemic blood into the pulmonary arteries. And another thing you always have to worry about is making sure that you're perfusing these coronary arteries. So through this type of conduit, I guess it just is better. So here's just more images. You can see there the BT shunt, which is some people use that, but everyone at Atrium uses the Sano shunt there. It's just larger image to kind of show the new blood flow. You want to make the ASD bigger, rebuild the aorta. Yeah. So second procedure, like I said, this one's done about 4 to 6 months of life. So the biggest thing with this one, you're trying to get direct head and upper body blood flow into the lungs. And ultimately, this reduces the volume, all the volume that we just put on the right ventricle to pretty much do all the work. So this helps reduce all that. So you're disconnecting the upper body vein, the superior vena cava, from the heart and sewing it to the lung artery. And with this, blood supply is actually going to the lungs instead of like it was before. This is simply done to bypass blood away from the heart and the pulmonary shunt of the right chambers diverting to the upper body. So kind of see here, you take the superior vena cava, which was hooked right here, clip it from there, and you're literally now just connecting it to the pulmonary artery. You're taking the shunt off, the Sano shunt or the BT, whatever the surgeon decided to do. You're closing it off there. You're still keeping the inferior. So right now you're just taking everything from the head, neck, upper body, connecting to the pulmonary arteries. And then, yeah, so that's pretty much it. So you can now see oxygenated blood, just oxygenated blood are now coming to and from the lungs. And just the mixing is now happening here. So this is obviously the middle step of it all. And the biggest thing what they used to do, which is the Fontan, when they first started doing this back in like the 60s or whenever, they tried to do it at the same time. And I guess just over time, the heart, as it was growing in the pulmonary arteries, it was just too much coming from both ends all at the same time. So the pressure, I guess, just the kid's going to outlive it. So that's why they made it into 2 different procedures, which is the Glenn and now the Fontan. So now with the Fontan, you're taking the IVC. So you're taking all the lower body and connecting it actually all the way up to the pulmonary artery. And all the ones that I saw, you actually need another conduit to put there because it obviously doesn't reach all the way up there. And it's honestly just like a little plastic thing. It's really smooth, it's really soft. And they size it up, measure it, literally just cut, sew it up again. It's pretty amazing. And then commonly you see this hole put in here, that fenestration, which just helps the blood flow. And most of the time it usually closes on its own, but sometimes in the next few years you're gonna have to go to the cath lab and they just like close it up. So the biggest thing with that fenestration, it helps with the pressure to preserve all of the cardiac output. And like I said, when you no longer need it, they either does it spontaneously or you go to the cath lab and they do all that work for you. But the best thing about this now, you can finally see all the red blood here, all the blue blood going to the lungs. So there's no more of that mixing that was happening when the child was born. So the biggest thing in between each of these procedures, I think I forgot to mention, but the Fontan is done at 3 years, when you're 3 years old, is you have to get a cardiac catheterization done in between each one. And the biggest thing for that is to check the pressures, making sure the pulmonary arteries are growing, they're good size, and that's done through an angiogram. And they have to almost pass that before they can even go to the next procedure. So here's a few images of the catheterizations. So this top one's after our Glenn. So you can actually see how just the superior vena cava is connected there to the right pulmonary artery and left pulmonary artery. And then you're obviously measuring the pressures, making sure everything's going through well, making sure everything grew as the kid's growing as well. And then here is after the Fontan, so after the third one. You can see now the inferior vena cava with the conduit going up to the RPA and LPA. You can see a little bit of that fenestration there. And then this is what I was talking about with how long the Fontan can last before the kid gets a transplant. Because when you're taking the IVC, you're also taking part of the hepatic vein. So that's why after kids have this, you're constantly monitoring their liver function. And once their liver function starts to go down, that's kind of when now it's their time for a transplant. So these are actually real drawings of my patient. So this is after, and it shows, don't ask what all these numbers mean, but it's pretty much just to show like the pressures and all the other stuff. Like I was saying before, make sure everything's growing to size. You can see he still has a small left ventricle, superior vena cava up at the right pulmonary artery. And then this is just after the cath, so that was before, and they obviously put a stent in there just to kind of open the pressure up a little bit. This is the next one. So this is after the the Fontan, sorry. So the last one. So you can see now the inferior vena cava is now connected as well as the superior vena cava. And then this one was after his heart transplant. So you can kind of see everything looks like a normal heart compared to what he was. He got this done when he was 3, and then this is when he was 10 years old. So like I said, final stage heart transplant. And then there's just stats up there, 3,500 heart transplant yearly, and 10% are cardiac. So it's just a little HPI, kind of the background. Obviously, this kid's been through the hospital system for a long time. So I kind of just summarize a little bit for you. So 10-year-old male demonstrating with a failing Fontan, so that's kind of normally what we call it, is evaluated and listed for his transplant. He was listed on the heart transplant in January. He was accompanied by his mother, who said he was pretty much at home. You could see his stats, like 80s, 70s. And obviously that's nowhere where you want any of us, let alone a kid at home. But denies any other cardiovascular problems. Those are just some medications that he's been on. And once they got all the liver function tests, obviously they've been following him since he's been 3 years old. They put him up for the transplant, and then on August 22nd is when we finally got the call. So here's just a little bit about a failing Fontan, just some research I did. The single ventricle patients start to enter that chronic form of heart failure from the time of the Fontan operation. Cardiac output is the biggest thing, and that's what I said at the beginning. Biggest thing with hypoplastic left heart syndrome is just kind of maintaining that cardiac output and make sure the blood flow. So the combination of chronically reduced cardiac output and the venous pressures, which is why we did the cardiac cast, it's just all those complications as well. And then you can see here 2 different studies that were done, that 33 of 273 children less than 18 undergo their heart transplant only within 3.5 to almost 4.5 years of transplant. The goal here is 15 years. You want your Fontan to last, which is the last procedure. But unfortunately, we're seeing a lot more within only 3 to 4 years when the goal is 15. Not going to read this to you. This is just pretty much this kid's problem list. And you can see how much he's been through. First, got diagnosed, had the Norwood done, the Glen, all the catheterizations he goes through. This is the biggest thing, that liver ultrasound I was telling you about. Once you see those mildly large liver, like they said, kind of falls along with what they see in most patients. And then the biggest thing I found interesting too, which is nothing I really was involved in, but all his developmental delays, autism, ADHD, it kind of, if you think about it, takes into account of any child in and out of the hospital literally his entire life. And the biggest thing too, once you get put on the heart transplant list, you have to stay in the hospital. So this kid's been in the hospital since January. And then obviously had the transplant done on the 22nd. So kind of to start my story of that day, I got the call at 9 p.m. the night before from one of the nurse practitioners asking me if I wanted to do this. And of course I was going to do it. And then she was like, all right, see you at 3 a.m. So 5 hours later, I was back at the hospital. And so I went down to Northeast, met them there in the emergency room, took an ambulance from the hospital to the airport, and we got on a private jet and flew up to Westchester, New York. So the Westchester Memorial is where the heart was. I kind of just put an image for a lot of people who aren't familiar with New York. Obviously, it's right above the city. Luckily, it wasn't in the city because I guess it's like crazy when that stuff happens, with all the traffic and stuff and ambulances. But the biggest thing, so this child, who was the one we got, was a 4-year-old female who got in a car accident, ejected from her car seat, and ended up being diagnosed brain dead on the 18th. Obviously, we were there on the 22nd. Really sad story, but my biggest thing, and that's why I'm like a big supporter of being a donor, this child now saved 4 people's lives. Like, obviously, it's very sad. We lost one, but she was able to save someone with a heart, someone with a liver, kidney, and pancreas. So that's really special. Just for fun, I just want to show you. This is where I was. That is where I'm from, in Washington, New York. To kind of show you the difference. Obviously, it's still far away, but it's kind of cool to go back home to New York for 2 hours. So biggest thing of transplant, it's all run through LifeShare of the Carolinas. And there's specific people, this is literally their job. They work for LifeShare. So we actually had one of them come with us during the transplant. He's the one that got the plane ready, the ambulance is ready, kind of do all the logistics behind the scenes to make it happen. So this is just kind of like to show you the mission of giving hope and life and healing to most counties in North Carolina. It was founded in 1970. That's the core purpose of it. And there's just a website if you ever want to check it out or even become a donor. And I put this image in. This is not the image of what it looked like, but think of this times plus 20 people. So when I walked in the room at like 8 a.m. in the morning, there was like 20 people in there. It was packed. And the biggest thing, you have obviously us, the heart team, you got the liver team, the kidney team, the pancreatic team. So total, I think there's a team from Miami, Pittsburgh, and Virginia. So obviously all flying in there, trying to get there at the same time, but it's chaotic and everyone's just talking and trying to get what they came there for. But the really nice thing about being a part of this too is a priest actually came in and said a prayer and all the stuff before everything. Just to kind of remind us of why we're even there in the first place and like say giving hope and life to those 4 other children. So then unfortunately I didn't get to scrub in for it because obviously the liver and kidney people brought like 5 residents with them. They brought everyone, their whole families. But the biggest nice part about this, obviously they weren't hooked up to anesthesia, which is normally right here. So they didn't even have this frame right here. So I was literally this person just standing right here looking over the head. And I was a timer person. So the biggest thing about a heart transplant is all about timing. So the goal is you want to, once you clamp the heart, I don't know how it is for any other transplant, but at least for heart, once you clamp it, you have a total of 4 hours to get it in the new child and get the first heartbeat. And I was the person who was calling the people in Charlotte, because at this time, like I said, we left around 3. The other half of our team was in Charlotte, starting the dig out of the other child, and making sure by the time we get there, so you put it in, sew it up, good to go. So I was the one kind of calling them down to Charlotte. Hey, are you ready? Because like I said, it's all about timing. And then unfortunately I had to call these Pittsburgh people too to make sure, because not only do we have to time up with our people, they have to time up with theirs. So you have to make sure the liver person's ready to go, the kidney person, all in this surgery, but also all the people all over the country. So like I said, it's a pretty organized thing. So here are just some pictures. This is the jet we took. Really cool. And then I think this is the funniest thing of all time. The heart's in there, and it's just like an igloo cooler that you would buy at a grocery store. And I just think that's really funny. I don't know. So I remember getting there in the ER and going to pick this up, and I even was like questioning them. Like, wait, this is the thing I put the heart in? So it's literally like an igloo cooler, and this is actually the life share guy that was with us. So that's the one we took to and from. This is just one of the ambulances that came to pick us up after the heart, and obviously rushed us back to the hospital in Charlotte. It's strapped, good to go, precious cargo. So I'm not going to read this to you. This is just kind of, this shows you just the operation in detail, and that's even me taking half of it out. And this is a picture of the heart, the 4-year-old heart, and actually, luckily, it was a pretty big size to fit into a 10-year-old, so there's no problems there. So kind of just a recap, I'm not going to read it for you, but the reason this takes so long is because this child just had 3 surgeries before that. So when you're doing these dig outs, you have so much scar tissue and so many like rods to get through. And so like that's why they started at 6 a.m. We probably didn't even get there till 11. So it takes a while to get all that through. And then they're also put on the cardio bypass machine, which I'll have a picture of that on the next slide. And it's pretty much just this machine that you hook up to like the superior vena cava. You have a catheter there, a catheter in the inferior vena cava, and then you also have a catheter in the aorta. It's pretty much while you're working in the heart, while you're cutting into the heart, so blood doesn't like come out at you and do everything. It brings blood and oxygen to the rest of the body while you're working into the heart. So this trial was also on that, and that's honestly something we use in probably 80% of the procedures I saw. Was a cardiac bypass machine. And another thing I found interesting is whenever you're doing any heart surgery, you want to decrease and make almost the room cold, and you want to make the patient's temperature really cold. And that's just to help control any pulmonary venous return and all that stuff. I'm trying to think what else. Oh, another thing that was really interesting was the order they did this stuff in. Like you would think it's just like cut, put it in, but there's a specific order in the way of like cutting each one off, and then when you put it in, you sew it up the opposite of the last thing we cut back in New York. So the order he put it in was the left atrium, inferior vena cava, pulmonary artery, and then the aorta. And then once all that's in, you obviously take the clamp off, and then you can see there within 2 minutes we had the heart pumping. And like I said, the goal was under 4. We did it in 3 hours, 50 minutes. And the max is 6 hours. That's when the heart comes to ischemic. But when I was talking to the surgeon about this, he says he starts sweating every minute after 4 hours. So his goal, in his mind, is 4 hours. So here's a picture of the cardio bypass machine. In perfusionists, you actually go to school for this. And I didn't really know what it was. I actually did 2 days with them. It's really cool. You see all these containers, and by the end of it, this is all filled with blood. Going in and out of the body, and it's obviously just a machine. It takes the function of the heart and lungs during surgery, maintaining the circulation and oxygen for the body. This is just CVICU now. But the biggest thing I just wanted to see here, like the amount of drugs in kids this patient was on. Obviously, he was still intubated when we took him up to the room afterwards. It ended up, we didn't get out of there till 7 p.m. For the last 3 hours. I was scrubbed in for it, but I was just a suctioner. I shouldn't say just, because tons of blood, tons of it. Not bad blood, but it was just from so many procedures. The way they explained it is just like irritated capillaries all over your thoracic cavity. So it's just trying to like calm them down. So I'm not exact. I had the suction literally for 3 hours. That was my job. And then obviously we took him up with a wound vac as well, because the heart is so inflamed. So we want to make sure that we release everything, and also helps with healing and just any inflammation and all that stuff. And those were the active problems following surgery. Allergies, medication, same thing. I don't know half of these. And then this is the physical exam. See that he's sedated, tachycardic, biggest thing was pulses, and then just a petechiae rash on his leg. And I'm not going to go over this either, but this was his entire assessment plan just the day out of surgery. You can see how many different teams are involved in this. So we're working with all of them and kind of just like helping them go from there. So this was the day after surgery. This was his assessment plan. And just last Thursday, he finally got extubated. So he's finally on the rise, and that was 10 days later. So you can see how long it takes to recover. Then this is nothing to do with it, but just a really cool photo of me actually sewing the aorta back together. So there's me sewing it. It does show how much I was shaking the entire time. And the biggest thing with these types of just all transplants, but even just like any open heart surgery, is they're at risk for so many different things. Making sure they're hemodynamically stable, hypertension, arrhythmias, pulmonary edema, any electrolyte imbalances, bleeding, infections. So this is the team. So this is the actual pediatric cardiothoracic team that I was with. That's Abby, the PA, Erica, the NP, and these are the 3 surgeons. So I flew up with Dr. Welke and Erica to New York. And then in the meantime, Dr. Maxey and Abby were in Charlotte getting the 10-year-old ready. Eventually, Dr. Kirschbaum scrubbed in. And then this is like the whole team part of it. So you had Dr. Maxey and Abby. That's a perfusionist. You always have 2 nurses, a scrub tech, anesthesiologist, CRNA. So you can see how many. And that was normal for any surgery. So obviously for the transplant, there's a little bit more people in there. This is Dr. Maxey and I. He has an Instagram. He asked for everyone to follow him. Super nice. And the one thing is not just like a normal Instagram. He actually posts videos every single week. And he actually just ended his segment on hypoplastic single ventricle stuff. He does videos and like Teammate Tuesdays follow up. And the biggest thing, and I already asked his permission too, but this whole scenario is the same exact thing that happened to Greg Olson's son. So he had left hypoplastic syndrome. He went through those 3 procedures. He got the transplant, and it was the same team who did it. And he posts all about it on his Instagram. So it's really cool. Definitely give him a follow. All my resources and questions. For all the people who don't know medical, I'm sorry if I tried my best to explain. Yeah.
So the heart being from a 4-year-old boy to a 10-year-old.
Correct.
Basically, there's a size difference, but you mentioned the heart being large.
Big enough. Yeah, so apparently part of the thing that they go into is when they diagnose the 4-year-old brain dead, they get all these echoes done and all these, she actually went to the cath lab and it actually measures the heart. So due to the size of this 4-year-old's heart, it actually was a good fit for this 10-year-old because it was larger. So they measured everything before we even got there. Does that make sense?
He was probably that small.
The
boy that got the transplant?
Oh, the 10-year-old? Oh, yeah.
He didn't.
Yeah, very underdeveloped, obviously pretty small, skinny, but yeah.
Do they recommend that it's like stuff like this going through all these years participate in basically no physical activity, or how does the physical activity?
A lot depends on how they do like vital signs wise. So the biggest thing, like you saw before he got put on the transplant list, he had oxygen levels 70s, 80s. So at that point, no. But obviously the goal after the Fontan is to get them back to a normal life. That's the goal of the Fontan. Like you could see that you had the blue blood and the red blood on different sides, but it doesn't always happen that way. But I would say definitely up until they're 3, they push it, but they also are monitoring them at the same time. So their goal is to get to that point, but they're constantly weekly, monthly appointments, checking their own oxygen, checking their glucose, checking all that. And then depending on the goal of the Fontan is even to get them maybe playing sports and stuff afterwards. So I would say not 100% being a normal kid until after the Fontan.
What's the diagnosis for the transplant as far as like how long will it last and how long will you be in the hospital?
So the biggest thing is, sorry, I looked this up, so I'm trying to remember. Transplant, hopefully it lasts until like being a normal person. That's the goal. I would say 80% lasts until they're actually in the 80s, and if everything's done correctly. But the biggest thing, especially to this kid, is depending on how long they've been in the hospital. And this kid has obviously been there longer than a normal transplant, I guess I should say. So who knows what their prognosis is like. But another really cool story, and if you're on Dr. Maxey on his Instagram posted about this, the oldest failing Fontan that was still alive. Because obviously to get a heart transplant, not just because you have left hypoplastic syndrome, you're already a candidate for it. You had to have all this other stuff to make sure you're a candidate for it. And unfortunately, this one female who had a failing Fontan wasn't a candidate for a heart transplant because she had, I forget what else she had, but she had all these other conditions. She didn't qualify for a transplant. And she actually just passed away last week. She's the oldest one, I think the third oldest in like the country of the failing Fontan. And she passed away at 48. And just to put in perspective too, heart surgery only started being done in the 50s, and she was 48. So it just kind of puts into perspective that they only had maybe 10, 15 years of even doing heart surgery before she got her first Norwood done. So it's kind of cool just to put into perspective how heart surgery hasn't actually been around that long. So yeah, any other questions? Yes.
You might not know this, but for the organ transplant stuff, is saying you want to be an organ donor on your license enough, or is there like
It is.
a registry?
Because I don't know the specifics of it, but I'm almost positive if you have that little heart on your thing, then you're an organ donor. Okay.